Hello everyone, my name is Emmanuel Palomera-Tejeda and I am a gastroenterology fellow at Baylor College of Medicine in Houston, Texas. As part of this author interview series, it is my pleasure on behalf of my co-authors to discuss our study titled Comparison of Anti-Migration versus Conventional Fully Covered Self-Expandable Metal Stents for Malignant Distal Biliary Obstruction, a single-center long-term study. Distal malignant biliary obstruction is a very common problem in therapeutic endoscopy, especially in patients with pancreaticobiliary malignancies. In these patients, biliary drainage is important not only to relieve jaundice and reduce the risk of cholangitis, but also to allow continuation of oncologic therapy. Fully covered self-expandable metal stents are widely used in this setting because they generally provide longer patency than plastic stents. However, stent migration remains one of their major limitations. Anti-migration stents were developed to address this issue. So, in our study, we compared a finned anti-migration fully covered metal stent with a conventional flared fully covered metal stent in patients with unresectable distal malignant biliary obstruction. Our main goal was to determine whether the anti-migration design translated into better clinical outcomes, particularly in terms of stent migration and recurrent biliary obstruction. This was a single-center retrospective cohort study performed at a tertiary referral center between April 2020 and April 2024. We included adult patients with unresectable malignant distal biliary obstruction who underwent ERCP with placement of one of these two fully covered metal stent platforms. The anti-migration stent was the Fin BI-Bill platform, and the conventional stent was the flared Wallflex platform. Then, to account for baseline differences between groups, we used inverse probability of treatment weighting, and we also performed propensity score matching as a sensitivity analysis. Overall, 276 patients met inclusion criteria, including 172 patients in the conventional stent group and 104 in the anti-migration group. Median follow-up was 222 days, and about 82% of the cohort had pancreatic cancer. So this was a very clinically relevant, real-world population undergoing palliative biliary drainage. In terms of results, we observed a lower crude migration rate with an anti-migration stent. Migration occurred in 13 of 172 patients, or 7.6% in the conventional stent group, compared with 1 of 104 patients, or about 1% in the anti-migration group. However, after inverse probability weighting, the adjusted hazard ratio for migration was 0.23 with a wide confidence interval, and this did not reach statistical significance. In the propensity score matched analysis, migration again remained numerically lower in the anti-migration group, but without statistical significance. Importantly, this reduction in migration did not translate into a significant difference in recurrent biliary obstruction. There were 63 RBO events overall, including 43 in the conventional stent group and 20 in the anti-migration group. The adjusted hazard ratio for RBO was 0.93, showing no significant difference between groups. Occlusion rates were also very similar, at 19.2% in the conventional group and 18.2% in the anti-migration group. Adverse events occurred in 17% overall and did not differ by stent type. There are a few important points when interpreting these findings, and this is where the discussion goes a little beyond the paper itself. First, migration events were infrequent. There were only 14 total migration events in the entire cohort. So although the direction of effect favored the anti-migration stent, the small number of events limited statistical precision. In other words, the study may simply not have had enough migration events to show a clear adjusted difference. Second, outcome definition is important. We used the TOCO 2014 definition of recurrent biliary obstruction, a clinically accepted composite endpoint. However, migration and occlusion are distinct mechanisms of stent dysfunction. Therefore, even if a stent reduces migration, this may not translate into a difference in overall recurrent biliary obstruction if occlusion and other causes of dysfunction remain similar between groups. Third, competing mortality is very important in malignant biliary obstruction. These patients often have limited survival, and many may not live long enough to develop late stent dysfunction. So even if one stent has a mechanical advantage, the real-world clinical benefit may be smaller than expected in a palliative malignant population. From a practical standpoint, our data do not fully support routine replacement of all conventional covered metal stents with anti-migration stents for every patient. However, the results do support selective use of anti-migration designs when minimizing migration is a particular priority. For example, this may be relevant in patients with shorter landing zones, larger duct diameter, or situations where delayed reintervention would be especially problematic. Our study also had several strengths, including a malignant-only cohort, standardized outcome definitions, and the use of IPTW and propensity score matching. At the same time, it had important limitations, including the retrospective design, operator-dependent stent selection, imbalance in stent lengths, and the low number of migration events. In conclusion, in this single-center long-term study of unresectable distal malignant biliary obstruction, the anti-migration fully covered metal stent showed lower crude migration than the conventional flared fully covered metal stent, but this did not translate into improved recurrent biliary obstruction or other major clinical outcomes. Overall, our findings suggest that anti-migration stents may be most useful in selected patients where migration risk is a particular concern, rather than as an automatic replacement strategy for all patients. Thank you very much for the opportunity to present our work, and we invite you to read the full article in Gastrointestinal Endoscopy.